see what it does. Okay. So thank you for sharing your information with us. We are trying to model real things because when you're in a math class and they say, well, we've got a farmer that wants to put a fence around a enclosure, everybody checks out. Maybe the farmer won't check out, but everybody else is gone. And so the first thing that we looked at was just follow-up visits from surgeries. And Dr. Dan Cardel talked to us about how patients don't return always for follow-up visits, and that ASMBS asks people to clinics to try to get at least 70% return rates. So I wondered first if you could introduce yourself and tell the class a little bit what you do, and a very related problem, the participant dropout.
Exactly. So I'm Dr Cardel. I'm an assistant professor at University of Florida's College of Medicine. And one of the areas of research that I have is developing and implementing pediatric obesity interventions with teenagers that have overweight or obesity. So the program that we've developed is quite intense. It's a 6-month intervention. They meet 15 times over the 6-month period. And teenagers are generally considered to be a high-risk population in terms of dropout and things like that.
Do you know what the pattern of your dropout is? I think it's pretty similar across the board. Do you get more at the beginning and then it tapers off, or?
Yeah, so we have worked incredibly hard to reduce dropout as much as possible. So for for us, that included doing a lot of formative work before we even developed the program. So we took what's called an adolescent engaged approach, or a community engaged approach, where we bring in the key stakeholder, and we did 10 focus groups to identify what are perceived barriers and facilitators to weight loss and healthy living, to understand what makes it hard to participate in this type of intervention. And then we asked the teens, what is it that they want in a program? So they gave us so much valuable information. And from there, we developed the curriculum, still utilizing the theoretical framework that we had planned for, and the therapy we had planned for, but really tailored it based on adolescent needs. And then we did writing groups with adolescent citizen scientists. So adolescents that we have tapped to be citizen scientists that we pay and compensate for their time. And they gave us feedback on all aspects of curriculum, told us how to make it engaging, how to retain the adolescents to prevent dropout. So essentially what they told us, which is not going to surprise any of you, that if it's not entertaining and engaging, then we're more likely to have more dropout. And so adolescents were really involved in every aspect of development. We hired them to develop our logo, to vote on the title of the program. So it's called the WATCH study, Wellness Achieved Through Changing Habits. So we see it very much as a program for teens, by teens, and taking on this approach of nothing about us without us. And so that has actually helped to, reduce dropout so much. The person that you saw previously, you're usually aiming for about 70% retention. In our study, we've been able to have 85% retention. And I think that's because we're utilizing strategies that the adolescents have identified for us. And of those who remained in the study, the 85% who remained in the study, 91% of them attended all 15 sessions and did all their post-treatment visits, which is really, really good, especially when you're dealing with a teen population. So I think that there's important strategies like stakeholder engagement that can really benefit the program, whatever intervention it is that you're doing. Because at the end of the day, I might have a PhD in nutrition sciences, but those teens have a PhD in being a teenager, in living the lived experience of being a teenager with obesity, for example. And so I think sometimes taking a top-down approach, where we as scientists or healthcare providers think that we know the best way without taking into account that population's preferences, needs, desires, barriers. We're losing an important aspect. So I highly engage taking stakeholder engaged approaches in developing interventions and to reduce participant dropout.
You know what? You could have just changed what you do to teach. And I'm thinking more about my own. We're trying to engage students by actually giving them real problems, right? But maybe they should be involved all the way when we design things. And I have that a little bit in my instructor points, but what you're saying is actually the same thing. I want to retain my students' attention. Mm-hmm. It's not that much different. And we think we know best, but probably they know best.
Yeah. Or a combination of the two. You bring a component of your expertise and they bring a component of their expertise, and it's really shared decision making.
Right. So I'll let you know how this goes. Would you like to work with us if we actually develop a model that hooks outcomes to patient? Would you like to? We're thinking that these are nice models. We have one for the bariatric surgery already.
That sounds fascinating. I'd love that.
All right, I'll let them know. Thanks a lot, Dr. Cardel.
Yeah, great to see you.
Good to see you too. Enjoy Florida.
Thanks.
Bye.
Bye.